So you would tackle either the dorsalis pedis, or would you approach the perineal directly, do you think, and try and rechannel this?
I think, yeah, I would probably I would actually try the dorsalis pedis directly.
Okay. Josh, you have any comments?
Yeah, I think
vein grafts down early, give him our best shot.
I think if you can elucidate that his graft just went down, if you can't determine based on his history that his graft has gone down within the last 24 hours, I think it's going to be really difficult to salvage a vein graft. And so if you can, and it's been less than 12, 24 hours, I think it may be worth a try. Otherwise, I think I would attack it from a contralateral approach or an antegrade approach, depending on his body habitus, and then do a magged up view, arteriogram distally, and see if you still have a decent distal target. If you don't really have a good distal target, I mean, you can see the perineal. I've accessed the perineal probably only a handful of times as my primary retrograde target, and there's some older bypass data that shows that if you can get inline flow to the perineal, you can still salvage distal tissue. So I think that would be the approach. If you can get even a small segment of either the DP or the PT, I think I would try to use one of those as my initial target, just because your only runoff vessel that you've got down there is the perineal.
Okay. Dr. Mills.
Yeah, I think this shows you clearly should have done endo first, Jay. I mean, look at where you are now. No,
obviously should have done endo.
A couple things. So did he get any, is he had any imaging at all after his original operation?
He did at 1 month. And there was
what did that look like?
There was no, obviously, abnormality of the graft that we could see at the time. But he hadn't come back for his follow-up.
So you have an early scan. Usually if you have an early scan, that's normal. I mean, a certain number will miss something.
Well, it does raise a question, in terms of the operative approach. Should we do intraoperative duplex? Do you do an intraoperative duplex scan to assess your vein grafts?
I don't anymore. I get an angiogram, but I get a duplex either before they go home or their first clinic visit. Yeah. So that, to me, that stratifies them. So normally, if your physical exam's normal and the first duplex looks normal, they're a pretty low risk for early occlusion, so I check them in 3 months. So how long has this guy been having pain?
Just about 4 days ago.
Now the other thing is, when you examine him, does the vein feel collapsed distally, or does it feel like it's firm?
I can't tell you that. I don't remember that.
Because some of these, they're pseudo-occlusions. They look occluded. You can have a proximal graft lesion that's really high grade, and there's almost no flow going through the graft. And if you put a catheter down there and find the orifice of the graft and wiggle a wire, you can find out actually there's a really high-grade stenosis. Mm-hmm. So I would explore that first. Mm-hmm. And if I could get in the graft, I'd actually try to lyse it just to see what I can get. It doesn't cost you a lot. And if you can get the thing open, maybe you have a distal problem, because it looks like you don't have the same quality of DP you had before.
Yeah.
So maybe you had a distal stenosis and you could get it open.
So here's what we did. We were able to get a wire all the way down through the graft, and in fact you could get a catheter down to the distal part of the graft, and the distal part of the graft is actually open. The proximal part is totally occluded. But it was able to be successfully lysed, and at the time finished after lysing this graft, we really couldn't really identify any flow limiting lesions at the time. So he was anticoagulated with Coumadin, and followed along every 3 months and did very, very well for another 9 months now after he was lysed. And at that time, then he had an elevated flow velocity just below the level of the knee, with a marked elevation in his flow velocity, kind of in this area where we had done this proline repair. And this is the arteriogram at the time. And the panel may not be able to see it very well, but there is some narrowing right in this area, right there. I think it's a subtle finding, but there's no question that there's a focal lesion there with maybe a short segment of narrowing right there in that vein. So now the question is, you've got recurrent stenosis here, and based on his clinical picture, he's been doing well for 9 months. Now you've got a high flow velocity. You've got a focal lesion in the graft. The rest of the graft looks pretty good. Are you going to do a balloon angioplasty or a balloon angioplasty and stent? Or are you going to go directly to a vein patch interposition or patch? Or are you just going to watch him for a while until he develops some symptoms? No symptoms at all now. His toe amputation is all healed up. He's not having any symptoms. This is on routine surveillance. So can we, everybody, pick a choice? What are you going to do? Can we see the answers? I guess we can't see there they are. Okay. So a few people are going to just watch and wait. Some people are going to go right to surgical revision, and some people are changing their mind. All right, so panel, comments, real quick, comments. Josh.
I think this goes to the whole philosophy of graft maintenance, and I think that the practice has changed and evolved a little bit over time, and I'm very aggressive with making sure that these types of bypasses are staying patent. And so if the whole purpose of doing surveillance ultrasounds is that you can find them before they're occluded and intervene on them in a much easier, safer manner than waiting until they're occluded and they're symptomatic and you've either lost that graft or not.
So you would do what?
I would do a balloon angioplasty.
Angioplasty? Dr. Mills?
Yeah, I would actually angioplasty that, believe it or not. I mean, for 20 years, I would have patched all these, but for a relatively short lesion, so you had 3 scans that looked pretty normal. This shows up at 9 months. It's not an artifact. It's not going to go away. So I would balloon it. We've actually had reasonable results with that for short lesions like this, and then you need to follow it really closely. If it recurs, I probably would just fix it open the second time, depending on the patient.
Tom?
I would do balloon angioplasty and then close follow-up.
So I think that correlates pretty much with the consensus of the audience. So this is that's the lesion again, and that's what we did. He got a pulse back, and 3 months later you bring him back for surveillance, and now he's got a high flow velocity again. So now, Joe.
What kind of balloon did you use?
I think it was a 3 millimeter balloon, but I don't remember I don't know how long it was. Yeah.
Yeah, I don't know if they...
It wasn't a cutting balloon.
Yeah, there's
it was
no
not a cutting balloon.
that it's better, but we've used cutting balloons for some of these. That one I might not have. If you felt you had did you have a normal scan after your first angioplasty?
I don't think he got one after the first angioplasty, actually.
So if you had a normal scan and then you have an early restenosis like this, I would probably just fix it because the graft is pretty superficial. If you go back and look and felt you had a suboptimal result, or maybe you were being careful not wanting to rupture the vein graft so you undersized it, I might try one more time with a bigger balloon or different balloon, use a scoring balloon or something like that.
So the question is now for the group and the audience is what would they do? Would they repeat angioplasty, or would you? Can I get this back on up here so I can see it? Would you do more serial examination or do an interposition graft? Agree with Dr. Mills, or would you just take down this bypass and plug it into that perineal that he had? It's a power button right here. Thank you. Great. All right. Everybody got your selections in? And then we're going to see what other people would do. All right, so most people would go back and do another angioplasty. All right. That again fits with the theme of the meeting, right? Endovascular. So he actually we underwent exploration. It turned out to be a longer segment stenosis, and it actually took a piece of short saphenous vein, did an interposition graft, and he is now 3 years out with what we would consider secondary assisted patency, has a palpable pulse, and has not had any further abnormalities of his flow velocity. So I think, is there any other discussion among the panel members? Yeah.
I think this just points out that you need to have all techniques available. These patients, there's very few patients where it's just one shot. You hear this argument, you may only get one shot because of the payment system. And that's just not true. That these patients, when we did them all open, if you followed those patients long enough, they got vein graft stenoses. You had to do target lesion relocation. Sometimes you'd swing the graft over a different vessel. You had to put a patch in. Same thing with angioplasty. I suspect if you'd started with angioplasty, you would have had issues also. So I think the key is to be dedicated to these patients and follow them really closely and try to be logical.
So I'd like to ask the panel, is there still a role for pedal bypass then for critical limb ischemia in this realm of new interventional techniques? Dr. B.
Yeah, I think you managed this patient extremely well, but you made a mistake at the beginning, and that was you should have done a popliteal to pedal bypass, which is an easier operation really, and then you'd have more vein left to do your revision with a patch or so forth. There's no reason to go to the SFA if you got a normal flow to the popliteal.
Good point. Jeb?
Great case. Joe, I'm interested in how your thoughts have changed about what you've emphasized so often is you need to know what your graft is doing when you're done in the operating room. So you mentioned moving from ultrasound to angio. So would you talk a little more about that? And then what is your follow-up routine now for these patients? So one has to do with looking at it and following it. And then I'd be interested, Tom and Josh and others, what do you put these patients on now? I mean, I'm sure they go on statins. Do they go on aspirin and Plavix? Do they go on Coumadin? I mean, Coumadin was used here. One of these new anticoagulants. What are your thoughts about the best medical management?
Yeah, I think our follow-up's still similar. So we always try to get a duplex scan either before they leave the hospital or in their first clinic visit. I've stopped doing that so much in the operating room just because it's cumbersome. I always do completion angios, but the key to that is to get more than one view and don't assume that everything's okay just because there's a good pulse, so be kind of suspicious. But I think that first duplex, we use that to kind of stratify them until everything looks pretty good, so I use my regular follow-up then, which is every 3 months for the first year. If the duplex shows something that's like a 250 or 275 at your anastomosis, then when they come back at 4 weeks instead of 3 months, then we get another duplex and follow them really closely. So the intermediate lesions, so intermediate means less than 300 or 350 peak systolic velocity, less than 3.5 ratio. About half of those actually go away, the early ones, if you just follow them. So if the graft has a good pulse, waveforms are pretty good, foot's healing, and you have a moderate type intermediate flow disturbance, we just follow them really closely. But if it gets to be more than a ratio of about 4 and a velocity more than 350 or 400, those almost never go away. So you need to do something. And then if they're focal, we'll try angioplasty. The other thing we do is we base a lot on how good your vein is. So if that same patient had poor quality vein, I would have tried endo up front. I agree with Dr. Beeth. I mean, he taught us how to do this really because the shorter the bypass, what that means is that it's less resistance because of physics, but also it allows you to optimize the vein. So sometimes you could do a little longer bypass and bypass some mild disease, but then you have to accept the segment that's not quite so good. So if you can get a really good conduit, I think that's key also to avoiding these lesions. But there's still no solution for this problem. It's a bane of our existence. It's almost no matter what we do, we get restenosis. As far as medical therapy, I mean, they all get aspirin, statin. If I do tibial angioplasty for a long segment, we give them aspirin and Plavix, but there's really no data that I know of for that. There may be some benefit to cilostazol. We don't routinely do that.